Θα περάσουμε τώρα στην επόμενη ομιλήτρια, η οποία μας έχει στείλει με βίντεο την ομιλία της και είναι πραγματικά πάρα πολύ μεγάλη μας τιμή ότι έστω και με βίντεο συμμετέχει. Είναι η Bathe Frates, η οποία είναι καθηγήτρια στο Harvard, είναι φυσίατρος και health και wellness coach και επίσης είναι η πρόεδρος στο American College of Lifestyle Medicine και μία από τις πρωτοπόρους σε παγκόσμιο επίπεδο και πιο γνωστές γιατρούς που ασχολούνται με την lifestyle medicine. Αν είμαστε έτοιμοι για το βίντεο, μπορούμε να το βάλουμε.
Welcome. I'm Dr. Bathe Frates, President of the American College of Lifestyle Medicine and Associate Professor part-time at Harvard Medical School in the Department of Physical Medicine and Rehabilitation. Delighted to be with you today to talk about a subject near and dear to my own heart, medical coaching and cardiovascular health. Together, we're going to define the problem of unhealthy lifestyles, demonstrate the power of healthy lifestyles, review the 5 A's of counseling, explain the importance of one of those A's, which is agreeing, introduce the literature on health coaching, and identify a 5-step cycle for coaching. We know that the number one disease that's causing death globally in the US is heart disease. And you all are specialists in this. Mokdad and colleagues put together a study that evaluated not only the diseases that are causing death, but also what was causing those diseases. And he called this actual causes of death. This was reported in JAMA in 2004, where he stated pretty clearly that lifestyles are killing us. What part of our lifestyles? The use of tobacco, poor diet, physical inactivity, alcohol consumption, and you can see the rest. We have 6 pillars in lifestyle medicine: exercise, nutrition, sleep, stress resiliency, social connection, and avoidance of risky substances. You can see many of them right here, at least 3. Mokdad and colleagues called this to our attention. The American College of Lifestyle Medicine was born in 2004. It's our 20th anniversary. I want to share that tobacco was number 1 then. Mokdad and colleagues did review the data in 2018, and at that time, poor diet was actually the lifestyle factor that was contributing the most to our chronic conditions, including heart disease. They were aware in the American Heart Association that poor diet was a major issue in the United States, and it was a goal to increase cardiovascular health by 20% by 2020. This was when the NHANES study came out in 2005-2006. On the x-axis here, you can see risk factors for heart disease. On the y-axis is the percentage of Americans. This is bar graph. Everything that has red is in poor control. If it's yellow, it's intermediate control. And if it's green, it's in good control. Let's draw our attention to those risk factors that have the highest red bars. That would be healthy diet score. Here you can see there's only a very sliver of green, which is ideal control of that risk factor. This is less than 1%. Then we see physical activity and body mass index. There were 30%, a third of the population was in poor control. Intermediate control for physical activity, 23%, body mass index, 32%. So there was a lot of work to do with healthy diet score, physical activity, and body mass index back in 2005, almost 20 years ago. And today in 2024, we have a similar problem. We haven't made much progress, and we need to change our approach. Instead of the sell-tell approach, we need to use the coach approach to empower patients to adopt and sustain healthy change. Because just prescribing medicines, just telling people what to do is not helping. We need life's essential 8. Partly we do need medicines, of course, to control blood glucose, the blood lipids, blood pressure, and nowadays you actually have medication to control weight. Even there's medicine for tobacco cessation. However, lifestyle can in fact put into remission diabetes, can help with weight, can help with blood lipid control, and can even put into remission high blood pressure when we change diet. And when we add exercise into the mix, we are even more powerful. What about sleep? That helps in all of these mechanisms for controlling these risk factors for heart disease. The essential 8 included some lifestyle factors I've already talked about: nutrition, activity, and sleep. Because these 3 have a great impact on these 5. This is near and dear to my heart because my own father had a heart attack and stroke when he was 52 and I was 18 years old, and I was dedicated to figuring out how to help him prevent a second one and how I could prevent a heart attack or stroke. And now, all these years later in 2024, my work is helping everyone to prevent a heart attack and stroke, and for those who have suffered a heart attack and stroke, to help them adopt and sustain healthy habits. Yes, part of this is knowledge. I wrote this book for that purpose, Life After Stroke, The Guide to Recovering Your Health and Preventing Another Stroke, with colleagues Joel Stein and Julie Silver. I learned a lot about exercise, nutrition, and stress resiliency, not as a pre-med at Harvard or during medical school at Stanford or during my internship at Mass General Hospital, residency in the Department of Physical Medicine Rehab at Harvard at Spalding Rehab Hospital. No, my own studies to write this book. And yes, knowledge is power, as Sir Francis Bacon said, but is not powerful enough to sustain lasting change. We actually need knowledge about behavior change in order for us as healthcare providers to motivate and empower patients around adopting and sustaining healthy lifestyles. Science is important. Information is important. The latest research will help. We need to personalize, individualize this information directly to the patient and what's important to them, what resonates with them, what motivates them. In the medical model, we know exercise helps prevent cardiovascular disease, helps reduce blood pressure, control blood glucose, control weight, and helps prevent obesity, helps prevent bone loss, can increase self-esteem, energy, improve mood, and decrease stress. We also know from the mental health model and a lot of literature that exercise helps improve sleep, gives us better endurance, reduces stress, helps improve our mood, increases energy and stamina, reduces tiredness, and this can help increase mental alertness, helps with weight reduction, and helps to increase HDL. That's hard to do even with medications, and it improves cardiovascular fitness. When we ask patients why they exercise or why they have exercised in the past, or if you ask your colleagues next to you later in this conference why they exercise, it'll be interesting to see how many of them talk about cardiovascular pathophysiology, cardiovascular risk factors, physical function, or psychological well-being. What resonates with people? It's important to have this data. So someone like me, you talk about fibrinolysis increasing with exercise, blood coagulability decreasing with exercise. And it does motivate me that endothelial function increases with exercise. That's because I'm a scientist and I'm a physician, and my dad had a heart attack and stroke when I was 18, so I have a family history. This resonates with me. This chart may not resonate with your patients. You need to know your patient. You need to understand your patient to actually be able to motivate and empower them for change. They may be worried about their brain health. In that case, you can show them your brain loves the gym. Show them that exercise increases dopamine, which helps with motivation, focus, and learning. Blood flow increases with exercise. That helps with delivering oxygen and removing waste. Serotonin increases with exercise, which helps with mood. Serotonin reuptake inhibitor medications work very well, and exercise works well to increase serotonin. Endorphins are released, feel good. We get a runner's high, many of us, when we exercise. Some get it when they do stretching. You have to ask your patient to see if they even get an endorphin rush. Norepinephrine helps improve attention, perception, and motivation. BDNF little known to many physicians and patients alike, that's released with exercise, and that protects and repairs our neurons from injury and degeneration. Hormones combine with BDNF, and that helps to increase the number of neurons, neurogenesis in our brain. It also helps regulate mood and provide mental clarity. Exercise itself can change the structure of our brain and increase the size of our hippocampus. MRI studies show the volume of the hippocampus can go up with exercise. This is essential information, especially for those that are worried about their brain health. What's good for the heart is good for the brain. It's all about our vascular system, as you know. Exercise recommendations, some people don't know this. We need to inform them and advise them. What are the medical guidelines around exercise? WHO and the United States Health and Human Services Department recommend accumulating 150 to 300 minutes of moderate intensity physical activity each week. If somebody's doing vigorous, they need half that, 75 to 150 minutes of vigorous physical activity in the week. Strength training twice a week on non-consecutive days is recommended for everyone. Now, after you declare these recommendations, somebody may wonder why. Why are these so important? And how do you get those benefits? Well, muscles are metabolically active. They release cytokines. This myokine is called irisin. It has an impact on the pancreas that increases beta cell regeneration and function, increases beta cell survival. It increases glucose uptake in the muscle. In fact, irisin also has an impact on the brain, and it helps with appetite regulation. This is important for patients to know. Some will be motivated by this, others may not. You need to know your patient. You need to know if that's something to share. You need to ask them, would you like to hear about how changes in your muscle may impact your brain? That's fascinating to some. Some may be sitting too much, and getting them up and moving is the key. You need to ask them how much they're sitting because you want them to avoid sedentary physiology. That allows for lipoprotein lipase to decrease, which brings triglycerides up and may reduce HDL. And we know too much sitting disrupts glucose. That's why the American Diabetes Association recommends that those with prediabetes or diabetes stand up every half hour, and other people need to stand up every hour. So I don't know if you stood up in the past hour, but I'll recommend that you stand up now if you'd like. We know that these healthy lifestyles are interrelated, and patients need to know this too. You need to ask them if they'd like to hear about how exercise is connected to intake of food. You can share. Exercise reduces urges for sugary snacks and attenuates urges in response to the stress situation and the cue in overweight people. You can share charts and graphs when you're talking about nutrition. We can all agree that we want to eliminate ultra-processed food or moderate, decrease to the best of our ability, ultra-processed food. Show them this graph with the x-axis, ultra-processed food consumption servings per day, and the y-axis, all-cause mortality. With every increased serving, they are increasing their all-cause mortality. They may wonder, what is a serving? You need to look at the package, and there's an opportunity to educate about how to read the package and the label. And for chips, 1 ounce is a serving, and that is equivalent to about 18 chips. Data on vegetables and fruits could be very compelling for many patients. You need to ask, would you like to hear about what the research has demonstrated time and time again about fruits and vegetables? In studies of 500,000 people, it's been found that a higher intake of fruits and vegetables is associated with a reduced risk of cardiovascular disease, an average risk reduction of 4% each additional serving per day of fruit and vegetable. This really resonates with some patients, especially someone like me, whose father had a heart attack and stroke at the age of 52. The nurses study compared with those in the lowest category of fruit and vegetable intake, less than 1.5 servings a day. Those who averaged 8 or more servings a day were 30% less likely to have had a heart attack and stroke. This data is compelling to some people. I do strive for 8. Now, individuals who ate more than 5 servings of fruit and vegetable per day had roughly a 20% lower risk of coronary heart disease and stroke compared to individuals who ate less than 3 servings. Some is good, more is even better, but getting 1 serving is powerful. Why is that? The antioxidants, the vitamins, the minerals, and the fiber. WHO recommends 25 to 29 grams of fiber each day because there's evidence that that can lower the incidence of type 2 diabetes, heart disease, stroke, and colon cancer. Because when we eat fiber, microbiome ferments it, creating short-chain fatty acids, acetate, propionate, and butyrate. These short-chain fatty acids play a key role in regulating metabolism, immune function, and cell proliferation. Some patients may be very interested in the science, others may not. You can ask, and you'll share if they're willing to listen. You can show them dietary fiber intake has an impact on gut microbiome, which ferments the fiber, creates short-chain fatty acids. Then they go through the L cell, acetate, propionate, and butyrate, which increase GLP-1 and PYY, proglucagon, L cell proliferation. And then that helps with the regulation of energy metabolism, glucose metabolism, lipid metabolism, inflammation, helps our immunity, and helps prevent cancer. In terms of sleep, the National Sleep Foundation recommends 8 hours, but why? It's because of data around cardiovascular disease. Y-axis has the hazard ratio for incident cardiovascular disease. X-axis has the sleep duration in hours per night. You can show patients this graph. 8 hours is the nadir here. We're looking for 7 to 9 hours of sleep to reduce our risk of cardiovascular disease. Now, we can assess and advise, and that's important. That fifth component, which was recently added, the agree, is essential. We also assist and arrange for follow-up with our patient. This is from data. When I first saw this in 2008, that's when I became a health and wellness coach and really decided that I need to learn everything about behavior change and lifestyle counseling and share this with all of my colleagues and as many patients as I possibly can. This interesting study is from 142 Dutch general physicians evaluating 212 video recordings of hypertension-related clinic visits. Here we have the duration of lifestyle counseling. So lifestyle counseling was not discussed in 60% of those videotaped visits. For half of the visits, it was discussed in 1% of those visits utilized half of the visit for lifestyle counseling, just 1%. A quarter of the visit on lifestyle medicine was only 6% of those videotapes. Hardly discussed was 32% of those clinical visits in the videotapes. Again, 60% of the visits for hypertension did not discuss lifestyle at all. So only 1% of those GPs were spending half the visit on lifestyle. This is the percentage of visits in which an assessment of lifestyle was performed. So weight was assessed in 22%, 12% assessed nutrition, 75% assessed physical activity, 9% assessed smoking. And then if you see purple, light purple, the patient initiated this assessment. If it is a darker, more maroon color, the GP initiated the assessment. Then percentage of visits in which the GP gave specific lifestyle advice to change behavior. Again, initiated by the patient would be in the light purple. The more crimson or maroon is initiated by the GP. You can see weight, 4%, nutrition, 11%, physical activity, 5%, smoking, 3%. So what was the advice they were giving? Try to lose some weight. You were too heavy. Now imagine if you received that advice. Limit your use of salt. Limit your alcohol use to maximum of 2 glasses per day. Keep in shape, keep cycling. Smoking is an important risk factor. It's most beneficial to stop smoking. It's more beneficial to stop smoking than to take an extra antihypertensive pill. These were quotes from those videotapes. Now, there's nothing wrong with saying that you need to limit your use of salt or limit your alcohol use or keep in shape, keep cycling. But do you know that that's motivating for the patient? Do we know what motivates the patient? Have we asked? That's the key. It's the asking. So we're recommending counseling. Assess the patient's motivation for behavior change. Assess the patient's confidence to perform behavior change. This is all asking questions when we're assessing. Assess perceived barriers or supporting factors. Agree on specific behavior change goals. Co-create those goals. Assist with finding the local gym, the YMCA, or the stress reduction class or program that they need in order to reach their goals. And then arrange a follow-up appointment for the evaluation of the behavior change, and they need accountability for the goals that they set. So which is better, advising or negotiating, selling and telling, or coaching and collaborating? Well, research tells us when you compare direct advice, selling and telling, to control or brief negotiation, to control. Brief negotiation and coaching around physical activity will actually result in increased minutes of physical activity. Direct advice and telling and selling compared to control will not change the minutes of physical activity. There will be no statistically significant difference. The only thing that makes a difference is actually negotiating and collaborating. That's what was different than the control. Control is just not doing anything. In this study, they talked for 20 minutes about negotiating, collaborating around physical activity, or here the physician talked about the importance of physical activity and gave direct advice and did the sell-tell approach for 20 minutes. So basically, it was a waste of 20 minutes because it did no better than control in this study. So just focusing on benefits and telling the patient the benefits is only one piece of the puzzle. You need to connect to their values, their strengths, get them to take responsibility and experience self-discovery. You've got to look at the obstacles, get strategies around those obstacles. The patient has to commit to change, increase their confidence. They need to feel support. There needs to be goals and plan in place. Behavioral small steps, SMART goals need to be taken into consideration and followed. Rewards, intrinsic rewards have to be there as well. It's all about problem solving and learning how to problem solve. And that's going to create lasting change, relapse prevention, and an enhanced self-image. When we talk about coaching, we really need to work on getting out of the expert approach. This article can help you to evaluate this concept further. In the expert approach, we follow the physician's agenda. We treat the patient, educate, rely on skills and knowledge of the expert, strive to have all the answers, and focus on the problem at hand. In the coach approach with chronic conditions, we need to help the patient help themselves, find the solutions to the problem, build motivation, confidence, and engagement, and rely on the patient's self-awareness and insights to solve these problems, and strive to help the patient find their own answers and strategies around the problems. Focus on what's working well, focus on their strengths, and collaborate with them to co-create the goals. Health coaching conversations do share knowledge, but that's after asking if the patient wants to hear information and what information resonates with them. And that involves a lot of listening. Asking open-ended questions and being curious and spending time trying to understand the patient and listening to them to help address the problem by having the patient tell you what they believe will solve the problem and co-create SMART goals with them. You don't take responsibility. You help the patient to take responsibility for their lifestyle behaviors. There's research behind health coaching, has been there for over 2 decades, and in cardiac disease specifically, Thale and colleagues looked at 792 patients. This is coach versus control. So in coaching, cholesterol dropped 21 versus in control, where it dropped 7 milligrams per deciliter. This has also been used in patients with diabetes, the coach approach, and the coach approach gives great results with significantly improved diet, self-management, less diabetes-related stress, higher satisfaction with care. And in fact, in terms of numbers with diabetes, the coach group has been shown to significantly reduce hemoglobin A1C compared to those in the control. It's not just for diabetes and cardiovascular disease. Coaching can be done with any patient. It has been utilized in patients with asthma, children with asthma, coaching the parents and the children as patients. This decreased rehospitalization compared to the control group, and that translates to dollars. Even in cancer pain patients, those that are coached versus control, those that are coached improve pain severity compared to the control. More data has been done over the years, and now we have so many randomized controlled trials. We have reviews of the randomized controlled trials, and cardiovascular risk is still something that is being evaluated. In this study, reviewing 15 randomized controlled trials in adults, significant effect was found in those coached for physical activity, dietary behaviors, management of stress, and health responsibility. Many different studies now in aging workers looking at improved well-being based on physical criteria compared to those who are coached versus control. And then we see meta-analysis of 10 randomized controlled trials in COPD patients. So there's improved quality of life, reduced COPD hospital admissions, again with the dollars. How do patients enjoy this? We're looking at face-to-face visits or versus telephonic visits. Now we're going to need to look at virtual visits versus in-person visits, and pharmacists are getting involved with health coaching. Cancer survivors are a population that have been studied, and coaching shows improved physical activity, mood, and quality of life. And there are several more studies to evaluate. I'm going to end, though, with the 5-step cycle that hopefully you can take home and try. Remember, with coaching, it's about collaboration, conversation, negotiation. The first thing is to get to know the patient, be empathetic, and have open-ended questions where you're curious about what's going on in their life, what they're struggling with, what has worked in the past, what their desires are for their future. Look at their motivation, ask about what motivates them, why they may want to adopt a healthy lifestyle with routine exercise, healthy diet, sleep, why they may want to control their blood pressure. And we need to build confidence, work on a strengths-based approach, set these SMART goals, specific, measurable, action-oriented, realistic, and time-sensitive, co-create them. You don't just tell and sell them. You ask what would work for them, check in on their confidence, then set accountability. And then we check in with the patient again when they come back to see us in follow-up. And that sets the cycle up again for deeper and deeper understanding and more movement and progress towards healthy lifestyle, adopting and sustaining for a lifetime. Thank you so much. The references are here for all those coaching studies that I shared in the charts. Thank you so much.
Νομίζω ότι γίναμε πιο σοφοί μετά από την ομιλία της Bathe Frates. Πραγματικά για μένα είναι η μέντοράς μου και η έμπνευσή μου στη lifestyle medicine και ακόμη και αν έχω ακούσει πολλές φορές τέτοια πράγματα, πάντα μαθαίνω κάτι καινούριο. Απλά έχουμε ξεφύγει από το χρόνο. Δεν ξέρω, κυρία Λαμπαδιάρη, αν θέλετε να σχολιάσετε πριν περάσουμε στη τελευταία ομιλήτρια.
Νομίζω ότι δεν χρειάζεται να σχολιάσω. Ήταν πάρα πολύ εμπεριστατωμένη και έτσι, βιωματική ομιλία. Και η ουσία ακριβώς είναι αυτή, ότι δεν εγκαταλείπουμε ποτέ, βοηθάμε τον άρρωστο για πάντα και είμαστε μαζί του σε όλα τα βήματα.